You can have someone sitting there in rest position and put EMG on their temporalis, and you'll get this, how's it, 2 microvolts, Barry, at rest? It just sits there. You'll just see very little neuroactivity. You'll ask the patient to elevate their mandible. Well, elevating the mandible through the air only requires a handful of fibers. You don't want to slam the teeth shut. You just ask the patient to elevate your jaw through the air just a little bit. So they will voluntarily innervate just a handful of fibers. The mandible will elevate a little bit, but you won't see anything on the EMG. It's not enough. If you weigh the Queen Mary and throw on 5 more suitcases, you can't tell the difference. But they're on there. So you've elevated this a little bit. You don't see anything. Well, let's have the patient elevate a little bit more. They're going to have to innervate more fibers. You still don't see anything that you can read. It's so minor. It's really, really, really easy for a temporalis to elevate a mandible through the air. As you keep innervating more fibers, you get a little more strength, a little more pull, but you don't see anything that you can read externally. It's too finite. Even if they can touch their teeth together and you won't see a significant raise of the EMG reading, you have to ask them to do this. You say, look, that's really great and everything. Now your teeth are touching. Still, nothing's happening. I need you to squeeze your teeth together as hard as you can. We'll call that maximum clenching voltage. So now they recruit as many fibers as they voluntarily can. Nothing has moved. Of course, there's resistance now to that mandibular elevation, and you'll get what they'll call their maximum clenching voltage. I think it's really weird that we have used that term, maximum clenching voltage, to describe a parafunctional act. Because later on, I'm going to call this a purposeless act. There's nothing normal, there's nothing purposeful, there's nothing masticatory functional about that activity. But we call it maximum clenching voltage in dentistry as if that's kind of okay. We all know that's what, as if that's part of normal, and it's not. When someone's in rest position, it's impossible to achieve anything close to maximum clenching voltage. You can't do it. You have to have teeth in contact to achieve any degree of significant contraction. You have to. If you put a conduit between these separated teeth, like a full coverage splint, now you have the communication like you do in clenching. So in that mandibular position, the position isn't what's significant here. Here's the mandibular position. It's at rest position. If I want to achieve significant clenching voltage at that mandibular position, I have to put a conduit between the teeth to have them connect, to make this, where I'm going to call it almost like a electrical connection. Now in that position, I have the patient clench at their maximum, and it's in excess of what it was when the teeth were together. I think that should be functional clenching voltage, functional masticatory voltage, because that splint is mimicking a bolus. As soon as your teeth touch, you're done. Why would your most efficient, intense, crushing power be when there's nothing between your teeth? What a waste. Well, in fact, that's when you're at your maximum, when there's something in between your teeth. And the thickness of the bolus or the splint dictates on how much intensity you can generate. That's why when you got something big between your molars, you can't bite very hard. Man, when you get like an ice cube gets shorter and all, poof, you really blast through it. Isn't it a bummer that a 2 millimeter thick splint can elicit clenching voltage beyond what they were doing without it? You've just enhanced their ability to do so in some patients. That's where I need to say in some patients. Because forever I kept presenting that a full coverage splint and a clencher, they'll clench harder. No, in some people, that they do. The point of this whole lecture is going to be identifying those people. If you modify the conduit and have it just posterior contact, you could still stay at your maximum clenching voltage. If you change the conduit and only have communication of the incisors, at that mandibular position, you can only achieve about 30% of maximum The jaw doesn't move at all. So now it looks as though it's the nature of the conduit, the nature of the communication of these teeth that dictates how many fibers you can recruit and innervate. So here's the motor nerves innervating the temporalis muscle, and we're going to be at our 0.2 microvolts. Here we are in rest position. And these teeth I look at more like, as a method of circuitry completion. It's the nature of the occluding scheme that's going to facilitate what kind of muscle contraction you're going to get. If you plug in the incisors, you create a circuit that allows for 30% of innervation of this machine, of this electrical motor, that muscle. When you plug in the canine teeth, now you've made that communication. Now you're enhancing the ability of the innervation of the elevator muscle, the temporalis. And in canine contact, you can get 75–80% of maximum with just the canines. Well, there's a purpose for that. Function obligates form. If you need to bite into something and hold it really tight, first you got to grab it. So the canines are designed that way to bite into something. And they're nice and long, and the roots are real long. So you can engage into another animal. So the bigger that canine is, the greater the temporalis. Those things are for clenching. Therefore, and we keep using them for canine rise, but this little picture you see me going like this on the internet. So when a tiger grabs a water buffalo and squeezes really, really hard, water buffaloes try to get away. They hate this part. And they pull and they pull and they pull, and your canine teeth are not ripped out of your skull. And they pull away hard, but the roots of the canines are really long. The reason why you have a real long root of a canine so it doesn't get ripped out of your skull, it's stable as you bite into something. When the tip of a canine engages something else, clenching activity is facilitated. So there's a purposeful function for that canine tooth, and when it engages, it allows that form allows for that squeezing. Molars, when they're engaged, allow masseters to squeeze, and they can move side to side a little bit. So herbivores, their masseters and their molars are huge. And once someone squeezes on like that, it's a life or death gig. When canines engage, you can squeeze for a long, long time, as long as it takes until whatever you're biting is dead. So now if you engage the circuitry in the molars, you're at maximum clenching intensity, maximum voltage to the clenching engine. But it doesn't happen instantaneously. There's always a function of time. Just because molars are together, it takes a while to achieve that maximum. When you watch Barry Glassman do his EMG presentations, he always has to say clench, 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 clench. It doesn't just boom. It's not like the light bulb and the wire, and you touch it, boom, and the light's on. It takes a while. There's a little bit of time required to achieve maximum. So when someone's jaw comes together, it takes a while to squeeze, 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 squeeze to get there. The reason why I'm mentioning that is because when people are moving, if you're moving, you can't be squeezing at maximum. You have to hold still for a moment and then you squeeze. If you're moving, just because you have posterior contact and canine contact, as long as you're moving, you can't be squeezing anywhere close to maximum. You've got to hold still for a little bit to generate that intensity. Later on, we talk about parafunctional. You'll find out things about the patient you didn't care to know. If you need to, incisal edge contact will maintain minimal muscle contraction intensity, minimal clenching intensity. That is, if you need to. Not everyone who has nocturnal parafunction requires full-time incisal edge contact when they're asleep. Some of them don't need that. If you need to do that, we're going to talk about in a little while why you would need to do it on some people, but in others you don't need to.